So the next speaker is Dr. David Bushinsky. Dr. Bushinsky is a professor of medicine and pharmacology and physiology at the University of Rochester School of Medicine, and was chief of the Division of Nephrology at the University of Rochester for 29 years. He has published many papers, chapters, reviews, editorials, focusing primarily on divalent ion metabolism, and is an expert on mineral bone disease, and gives an absolutely wonderful talk to us every year. Thank you so much, Dr. Bushinsky, for coming back and doing this again with us. Appreciate it, as always.
Thank you so much. It's always a pleasure. Good morning, everyone. We're going to talk about chronic kidney disease, mineral and bone disorders. As was said, I'm at the University of Rochester, where I ran the nephrology unit for a long time. Received my MD at Tufts, my residency. I stayed there, stayed on for a fellowship. I went to the University of Chicago for almost a decade before coming here to Rochester, where I've stepped down as head of the division, but I'm still active intellectually. We work on the effects of acid on bone. We've developed a genetic model of kidney stones, and we study kidney stone formation. My research support, I have 2 grants from the NIH. I really have no other conflicts except I own some stock in Amgen. So let's think of a typical patient that we all see in clinic every day, every week. 66-year-old obese Black male, hypertension, diabetes. His BMI is pretty typical for my clinic. His diabetes for 20 years, moderately well controlled. His hypertension, 35 years, not as well controlled as we would like, but that's his typical blood pressure. He's on an ARB, he's on a loop diuretic, he's on insulin, multiple vitamins, and vitamin D3. His GFR when we first saw him was 9, potassium 4.8, calcium 9.2, phosphorus a bit elevated at 5.6, 25D was sufficient at 25, and PTH is up a bit. Over the next 6 months, his GFR fell. GFR was 4, potassium's up a bit, calcium's okay, phosphorus again increased somewhat. 25D fell a little bit, as you'd expect, and we'll talk about that. And his PTH went up further, again, as you would expect. We'll talk about that. Has nausea, lethargy, weight loss. I think we'd all start someone like this on dialysis. The questions we're going to address over the next 2 lectures are: what do we do about phosphate binders? What do we do about vitamin D? Do we think about a calcium mimetic? We clearly want to know if he's at risk for vascular calcification, and what can we do to prevent it? So let's go back to Go's study, 2004, but a landmark study, where on the left you see the rate of death from any cause. As the GFR falls, the rate of death goes up prodigiously. And the rate of cardiovascular events also goes up incredibly from a GFR pretty normal to people almost on dialysis. So as people develop CKD, they are dying, and they are dying from cardiovascular events. What about dialysis? Dialysis patients, whether male, female, black, or white in orange, have an incredibly high annual cardiovascular mortality compared to non-dialysis patients in the same groups. A 30-year-old dialysis patient has over 100-fold increased cardiovascular mortality compared to a non-dialysis patient. This line is relatively flat. A 30-year-old dialysis patient doesn't do much better than an 80-year-old dialysis patient. And what's really chilling to me is a 30-year-old dialysis patient has about the same cardiovascular mortality as an 80-year-old non-dialysis patient. So our dialysis patients are dying, our CKD patients are dying. And as we see from this renal USRDS annual report, about half of these deaths are due to cardiovascular disease. This is from 2023, so there's a number of COVID deaths, but in general, cardiac arrest, arrhythmias, CVH, CHF, AMI. People are dying from vascular disease. These are dialysis patients. So our dialysis patients have the traditional risk factors of smoking, diabetes, hypertension, lipid abnormalities. They also have some novel risk factors of inflammation, oxidative stress. What we're going to focus on today is the uremia-specific risk factors of phosphate retention, hyperparathyroidism, and vascular calcification. This is what's killing our patients, the cardiovascular risk factors. So back in 2009, the term CKD-MBD was caused. It was come up with, and it linked the laboratory abnormalities of elevated fibroblast growth factor 23, parathyroid hormone and phosphorus, and decreased 125D and calcium, with abnormalities in bone and with vascular and soft tissue calcification. And the overall hypothesis was that if you corrected these laboratory abnormalities, you would have a beneficial effect of reducing calcification and improving the bone. We met again about 2 years ago and reviewed these factors, and the authors came up with something that was a little more direct and a little perhaps more suited to direct patient care. And it talked about the CKD risk factors in the immune system, the gut, the endocrine, uremic toxins, and the mineral metabolism disturbances came down with two big classes of patients: those with cardiovascular disease and cardiovascular-associated CKD, and those with osteoporosis and CKD-associated osteoporosis. So these are the people who are dying of cardiovascular disease. These are the people who have severe bone disease and fractures. They come up with thoughts about biochemistry, imaging, pathology, molecular studies. We'll talk about this later. So what is the pathophysiology of CKD-MBD? Well, typically we all eat, at least in the US, about 1,200 milligrams of phosphorus a day, of which we excrete 400 milligrams, meaning the net absorption is 800 milligrams. We absorb some, we secrete some, but really 800 comes into the phosphorus pool. In healthy, non-pregnant, non-growing, non-osteoporotic people, bone formation and bone resorption are equal. And through the marvels of integrated physiology, that 800 milligrams of phosphorus, which is absorbed, is excreted into the urine. All is well. You're in perfect phosphorus balance. So let's stop for a second, take a little right turn here, and ask a question. 1,000 international units of oral vitamin D3 per day will directly, you can read it, increase intestinal calcium absorption, increase phosphorus absorption, increase bone mineralization. Why don't you vote on what you think is the best? And we'll discuss the answer, not only in terms of physiology, but in terms of how to address a question like this. Okay, everyone's voting. Okay, so let's think about the right answer. We know 125D itself, D3, is a prohormone. It has to be hydroxylated in the liver, and then the second hydroxylation has to occur in the kidney to form 1,25D3, which is the active hormone. 1,000 international units of D3 alone isn't going to increase intestinal calcium absorption. So A, B, and E are out. You're left with C and D. So C is not alter intestinal calcium absorption, not alter phosphorus, not alter bone mineralization. That sounds good to me. Let's look at D. This says it will increase intestinal phosphorus absorption. Since this is the prohormone, and the prohormone has very little biological, almost no biological activity, C is the correct answer. If you understand the physiology, these questions are easy. Let's move on. So you see that most people are increasing intestinal calcium absorption, phosphorus, and bone mineralization. Ultimately, you need vitamin D3 to do all of these things, but itself, it will not directly do any of them. Okay? As CKD, MBD progresses, we see several things happen. One, 125D3 falls. We used to think that was because of reduced renal mass, since the second hydroxylation of D3 occurs in the proximal tubule of the kidney. We said as the kidneys shrink, become sclerotic, you'll reduce mass, you'll have less 125D. In fact, there's sufficient tissue. What happens is FGF23 goes up, which directly inhibits 125D3. PTH goes up. As we'll see, PTH stimulates 125D, but the FGF23 wins out. FGF23 goes up with CKD. It goes up very early and increases, I want to say exponentially. It's not quite exponential, but perhaps it is exponential. It's a clear rise in FGF23. The net effect is that corrected calcium is relatively flat, but phosphorus begins to rise. And phosphorus rises in virtually all of our patients with CKD. Let's think about phosphorus absorption. In the proximal tubule, phosphorus is absorbed through three active transporters, NAPI2A, NAPI2C, PIT2. There's also some paracellular phosphorus absorption, which we're only recognizing recently. What's important in this slide is both FGF23, when it's linked to its cofactor klotho, and PTH, when it's linked to its receptor, downregulates NAPI2A and NAPI2C. So there's less transport of phosphorus into the cell, more phosphorus goes out into the urine. That's why FGF23 and PTH are phosphaturic. What's the difference between them? FGF23 is made in the osteoblasts, also the osteocytes. PTH is clearly made in the chief cells of the parathyroid gland. Principal stimulus of FGF23 is phosphorus load and hypophosphatemia, but there are at least 8 other factors that stimulate FGF23, including acidosis. Hypocalcemia is the principal regulator of PTH. Yes, 125D can regulate PTH, phosphorus can regulate PTH, but on a scale of 1 to 10, hypocalcemia, calcium, is number 10, and the other 2 are kind of like 3s and 4s. FGF23 is a principal regulator of phosphorus. PTH is also phosphaturic, but causes the increased reabsorption of calcium. So PTH affects calcium and phosphorus, FGF23 only phosphorus. The clear difference is FGF23 decreases 125D production, while PTH increases it. It's a key fact that you should remember. So that's another question. With respect to phosphorus, an acute infusion of FGF23 will promptly, for this one, we know that FGF23 is phosphaturic. I'll let you answer this before I start talking. Let's do well on this one, everyone. I don't see a lot of votes. Don't be shy. So with respect to phosphorus, an acute infusion of FGF23, you want to know it's phosphaturic. So clearly it'll increase urine excretion. So A is a possibility. B is not a possibility. C is not a possibility. D is a possibility. E is a possibility. F is not a possibility. So we've already decreased the odds of a wrong answer by 50% because we knew one fact, that FGF23 is phosphaturic. So then let's move back. Will it increase tubular reabsorption? Well, if it increases tubular reabsorption, it decreases urine excretion. So that's clearly wrong. So A and D, A is wrong. D and E are possible because they increase urine excretion, decrease tubular reabsorption. So we have two possibilities. Can it increase filtered load? No, because once you excrete the first microgram of phosphorus, the filtered load is going to go down. So D is the only possible answer. So if you understand the physiology, these questions are quite easy. So let's look at what happens with time. The first thing that falls is Klotho. We'll talk about Klotho. FGF23 goes up, PTH goes up, 125D falls, and only when these regulators, these four regulators of phosphate, fail to keep phosphorus in line does serum phosphate go up. All of these things regulate phosphate, and only when they do, only when they fail in the regulation, does phosphate go up. So let's think about CKD-MB. Let's think about CKD-MBD. FGF23, PTH, 125D are the key players. We said both PTH and FGF23 are phosphaturic. FGF downregulates 125, PTH upregulates 125. Since 125 falls, it's very clear that FGF, the effect of FGF, predominates over the effect of PTH. The fall in 125D decreases calcium absorption and increases phosphorus absorption in the intestine. Increase 125 increases phosphate absorption. So if you decrease 125D, you'll decrease calcium absorption, you'll decrease phosphorus absorption. That's perfect. You can't excrete as much calcium and phosphorus, you're decreasing the absorption by decreasing 125D. Physiology is beautiful. But what happens if you as a doctor give your patient large amounts of 125D? You'll cause an increase in phosphate absorption. You'll cause an increase in calcium absorption. You'll be telling the patient, why is your phosphate high? You must be eating too many, Big Macs and milkshakes, when in fact you're inducing an increase in phosphorus by giving that patient 125D or the analogs. So the patient should be telling you, Doc, you're the one who's causing my phosphate to be increased. The physiology is to decrease 125D to decrease calcium and phosphorus absorption. So this is a more FGF, PTH, 125D. This is an older slide that I'll show you. And a decade ago, we really just talked about secondary hyperparathyroidism, and this is a PTH centered, literally centered slide. But in fact, now we're thinking more that it's really a triumvirate of PTH, FGF, and 125D. So let's think about that parathyroid gland. I had yogurt this morning. I increased my serum calcium just a wee bit. My PTH probably fell. And in a daily basis, minute by minute, my PTH, your PTH, is going up and down. However, if I didn't eat that calcium for days and days and days, my parathyroid hormone would start going up. And in our patients with CKD, that normal adaptive response gets stimulated into a maladaptive response. And you start developing a polyclonal enlargement of the parathyroid glands. And the important thing is receptors for calcium and the receptors for vitamin D begin to fall. And then the gland becomes less responsive to perturbations in calcium and vitamin D. The glands increase in size. They become monoclonal. They become nodular. Look at this beautiful, except if it was yours, view of a large nodule of parathyroid hormone, monoclonal, low vitamin D receptors, low calcium receptors. So that nodule is not as responsive to an increase in serum calcium and not as responsive to vitamin D. It just keeps secreting PTH. PTH is now 1,000, 2,000, time to call the surgeon. So why does the phosphate go up? Why do we retain phosphate? Well, clearly it goes up. We know that PTH goes up, that's phosphaturic. We know that FGF23 goes up, that's phosphaturic. So the fractional excretion of phosphorus, that is that phosphorus presented to the proximal tubule, which is ultimately excreted, that fraction clearly goes up. But 24-hour urine phosphorus goes down. This is the problem. The decrease in GFR is greater than the increase in fractional excretion. So the 24-hour urine phosphate goes down. That's a problem because we're still eating our gram of phosphorus. We're still absorbing our gram of phosphorus. If we're giving the patient exogenous vitamin D, they're absorbing even more, and urine phosphorus goes down. So the body is retaining phosphorus. If you look at this diagram that we had before, same food intake, same absorption, same phosphorus pool, it coming in from the intestine. From bone, it's being broken down because of an increased parathyroid hormone. So you're getting more phosphorus coming in from the bone, equal amount of phosphorus coming in from absorption. Excretion goes down. We showed that excretion goes down. So now we have a problem because we're retaining phosphorus in the body. And where does that phosphorus go? It has to go into the vessels. It has to go into the soft tissue. There's no other repository of phosphorus in the body because the bone is being resorbed from a high PTH. So what are these deleterious effects on mineral metabolism? As renal function goes down, phosphorus concentration goes up. The higher the serum phosphate at presentation to renal clinic, the greater the decline in renal function. In this interesting study by Kestenbaum, he divided the patients coming into clinic into 5 groups, quintiles. The lowest phosphorus had the best survival. The highest phosphorus had the worst survival. This is a classic study. This is Jeff Block's study from 2 decades ago. It has been repeated at least 20 times, maybe 25 by now. But it really shows that the relative risk of death goes up as phosphorus goes up. Calcium, the trend is positive. PTH, only at the highest thyroid hormone, does the risk of death goes up. The biggest player here is phosphorus, about a 2-fold increase of the risk of death at the highest phosphoruses. But FGF23 is a worse actor. The hazard ratio of death in the pre-dialysis patient goes up with the highest FGF23. In the dialysis population, the highest FGF23 levels are associated with an incredibly high odds ratio of death, almost 5 and 6-fold increased death. Remember, the highest phosphorus was 2-fold. The highest FGF23 is 6-fold increased risk of death. For FGF23 to work, it has to have a co-receptor, which is Klotho. Klotho has been termed the fountain of youth. Klotho protects against renal fibrosis, promotes kidney regeneration after ischemic injury. It inhibits vascular calcification, reduces oxidative stress, increases nitric oxide production, which is a vasodilator, as you know, inhibits cell senescence, preserves stem cells. In normally, Klotho teams up with FGF23 and has all the effects. If you have decreased kidney function, the first thing to fall, as I showed previously, is Klotho. That, since it can't team up with FGF23, phosphate goes up, 125D is going down. Klotho is a primary actor. Calcification. This is Leslie Stevens did a great little study. She looked at the relative risk of mortality, looking at phosphorus, calcium, and PTH. You can see if phosphorus is normal, calcium is normal, FGF23, you'll see doesn't matter, or PTH doesn't matter very much. That's a relative risk of mortality of 1. If calcium goes up, the other two don't change, risk of mortality goes up. If phosphorus goes up, calcium's normal, same deal. Increase calcium here, increase phosphorus there, high PTH. But if PTH is lower, it doesn't matter. This is high phosphorus, low calcium, doesn't matter. The worst is if both calcium goes up and phosphorus goes up. It doesn't matter really what the PTH is, the relative risk of death goes up prodigiously. We're going to have 2 basic science slides. Yang increased phosphorus with the normal calcium, and these are in vascular smooth muscle cells in culture, and then measure the amount of calcium per milligram of protein in the cell. And you can see there's more calcium by just increasing the phosphorus. If we have a normal phosphorus and increasing the calcium, same deal. As you can imagine, if you have a high phosphorus, and this phosphorus is 6.19, and I suspect we all have lots of dialysis patients have phosphorus is in excess of 6.19. You increase calcium at that high phosphorus, you get incredible calcification of this vascular smooth muscle cell. How does that happen? This is Giacelli's work. Again, others have done the same study. Increase phosphorus, you increase phosphorus, sodium phosphate transport into the cell, increasing intracellular phosphate. That increase in intracellular phosphate upregulates CBFA1, the factor also called RUNX2, which leads to increased alkaline phosphatase, increased calcium binding proteins, increased collagen-rich extracellular matrix, and increased calcium phosphate-loaded matrix vesicles. So you've taken a vascular smooth muscle cell and made it into an osteoblastic cell, into a bone cell. And in the presence of increased calcium and phosphorus, that matrix mineralizes, and you get a ring of calcification around that vessel. And instead of distension during systole by the major arteries and contraction during diastole, you have a rigid pipe. That pulse pressure is transmitted to the downstream organs. They don't do well. Phosphorus also does bad things to the vascular cell. It causes inflammation, decreases nitric oxide, decreases new vessel formation. If you really want to look at it, we talked about this CBFA1. There's also inhibitors of calcification, agonists of calcification. What's really very interesting, and Wei Chen and I have written about this, is that you now have passive deposition from calcium-protein particles and primary particles, secondary particles. All of this leads to calcification of the vascular smooth muscle cells. What are the consequences? The first thing, and probably the most important thing, are the next few slides. Plasma calcium is a trivial amount of total body calcium, 0.03% of total body calcium in the plasma. Most of the calcium, as you know, is in bone and teeth, some in soft tissue, some extravascular, but really plasma calcium is the very tip of calcium. When our patients develop CKD, you see this is calcium loading in the vessels in pre-dialysis, and these are dialysis patients. And these are children, so they don't have all the cardiovascular disease if you were doing this study in adults. These are kids with pristine vessels. They develop CKD, they start calcifying their vessels. These are our dialysis patients. This is, 7 studies out of 700 in the literature. The number of patients who have calcification is higher in diabetics than in non-diabetics, but clearly the closer you look, the higher it is. The percentage of CKD patients with coronary artery calcification goes up from CKD to those on incident dialysis, and those are prevalent dialysis. These are 3 studies that are important. Rousseau, Spiegel, and Chertow. We'll talk about them on the next slide. Those are those 3 studies. And then this is a Bill Goodman study on kids. And you see the patients with cardiovascular calcification is pretty high in prevalent dialysis patients and in young dialysis patients. This is the most important part of this slide and perhaps of the talk. There is no difference in serum calcium in any of these patients. If you have protocols in your dialysis units that you can give calcium-based phosphate binders to patients with a normal serum calcium, you're kidding yourself, because a normal serum calcium does not predict calcification. It just simply doesn't. There is no difference in serum calcium in any of these groups, in spite of the fact that they have vast differences in cardiovascular calcification. More calcification, less survival. If more arteries are calcified, this is Blatcher's study, if 0 arteries are calcified at time 0, patients do real well. If 1 out of 4 arteries are calcified, not as well. 2 out of 4, even worse. 3 out of 4. 4 out of 4. If 4 out of 4 arteries are calcified, at the time that you first see the patient, their survival is far worse than most malignancies. Calcification is killing our patients. Our patients have this medial calcification that I've been talking about this whole time. It causes vascular stiffness. We have linear deposits along the elastic membrane. That's what the high phosphorus is doing. It's stimulating those vascular smooth muscle cells to become osteoblastic cells and calcify. Yes, our patients may well have intimal calcification, just like your non-CKD patients. They're not immune to it. Clearly, intimal calcification for all-cause survival and cardiovascular survival is worse than medial calcification. But medial calcification is also a killer. It adversely affects survival, adversely affects cardiovascular survival. Let's think about bone disease. Renal osteodystrophy is an alteration in bone morphology characterized as abnormalities in turnover, mineralization, volume, growth, strength. It's one measure of the skeletal component of CKD, MBD, and it's quantifiable by bone histomorphometry. When we used to do bone biopsies, and I have to say we rarely do them anymore, we talked about adynamic bone disease, normal bone formation, and high turnover bone disease or osteitis fibrosa. You can see in adynamic bone disease, there's virtually nothing going on. There's very little osteoblastic formation, very little osteoclastic resorption. In a mixed lesion, you have some of both osteoblast and osteoclast overactivity. But in high turnover bone disease, you have incredible osteoclastic bone resorption, incredible osteoblastic bone formation. But the bone here is not nice, lamellar, strong bone where the fibers are oriented to prevent stress, to counteract stress. It's just woven bone. The fibers are going in all different directions. It's not strong bone. So the turnover is low here. It's high in these two disorders. Mineralization is abnormal across the board. The volume in adynamic bone is low. The mixed lesion bone is low. In high turnover bone disease, the volumes actually increase. But as I said, the bone's not strong bone. You can see how in any of these cases, there's increased risk of fracture. When one of these patients falls, they fracture where someone else would sort of get up with a bruise. If we look at bone biopsies, and again, we're not doing very many, we see that many more patients now have low turnover bone disease with low volume. We used to see a lot of high turnover bone disease down here, not so much anymore. It's low turnover bone disease, probably because we're giving our patients a lot of calcium and vitamin D. Does this bone disease affect fracture? This slide shows that if someone has no osteoporosis and no CKD, they have a better fracture-free survival than if they have osteoporosis or CKD. If they have the combination of osteoporosis and CKD, which is very common, they have a worse fracture-free survival. The overall risk for hip fractures in CKD, look at this meta-analysis. Overall, it's almost threefold, 2.36-fold. And virtually every study shows increased risk. Who gets it? Well, if you look at the younger patients, they seem to fracture more than the older patients, perhaps because they're more active. Don't know why, but they clearly do. But overall, again, we have this threefold difference. If we look at CKD3, verse 4, verse 5, we see that the higher stage of CKD, the greater the risk of fracture. And again, we come up with this number. This is 2.56, but we're starting with some CKD3 patients. Our patients are fracturing. So you say, so what? The patient fractures their hip. They go into ED, that the orthopod pins it the next day, and they walk out and are on their way 2 weeks later. Well, look at dialysis patients who don't fracture. Mind you, they don't do very well after 5 years. But those who do fracture do far worse. There's virtually no one alive 5 years after a hip fracture. And I'll tell you, in non-dialysis patients, women who fracture a hip, who are older, osteoporosis, fracture a hip, 80% of them don't do as well a year later as they did before they fractured a hip. That's another lecture for another time. We used to do bone biopsies. Almost no one does bone biopsies anymore. And even if you can find someone to do the biopsy, which actually isn't very hard, getting the biopsy interpreted is also pretty hard. In most recent KDIGO report, they stress the fact that you really don't need to do bone biopsies. You can look at bone turnover markers. PTH is high in high turnover bone disease, low in low turnover disease. The markers of bone formation, alkaline phosphatase, bone alkaline phosphatase, and procollagen type 1 polypeptide, P1NP, high with high turnover, low with low turnover, and the best bone resorption marker, which is tartrate-resistant acid phosphatase, isoform 5B, is high here, low here. I don't have absolute numbers because there are different assays, depends on the assay, but directionally, it's very clear. You don't really need a bone biopsy anymore. You can use the markers of formation and resorption, especially P1NP and TRAP5B, to determine if the patient has high turnover versus low turnover. Why is that important? Because if they have low turnover bone disease with CKD3, for example, you really don't want to give them a bisphosphonate, do you? That'll only make it more low. If they have high turnover bone disease, bisphosphonate might work. This is an interesting slide. We talked about Clotho. This suggests that if we gave our patients back Clotho, we might project regeneration after insult. We might have antifibrosis. We might improve, mineral metabolism. And we might decrease end organ complications. Clearly, you can't give people Clotho yet, but it's just an interesting thought. So we started out in 2009 talking about the elevated FGF23, PTH, and phosphorus, decrease 125D in calcium, and how they adversely affect calcification in bone disease, and how normalization may well prevent calcification and abnormal bone disease. We then talked about how CKD-associated cardiovascular disease is killing our patients, and CKD-associated osteoporosis are leading to fractures, and our patients don't do well after they fracture. Here's a list of references. In the next talk, we're going to address how to treat these disorders, how to prevent the calcification, how to prevent the bone disease. We'll do our best. We have 1 minute extra. Thank you.
Great. Thank you, Dr. Bushinsky, for an excellent presentation, as always.
Thank you, sir.